Welcome to the second season of Social Work Live at the Columbia School of Social Work. I'm Michael Friedman. I teach health policy and mental health policy here. And each week I have the pleasure to interview somebody from our community to discuss the latest in social work practice. And I'm going to be interviewing Allen Zweben today, who is a professor here and who's got a remarkably eminent career as a researcher in the field that we're going to be talking about. We'll talk just the two of us for about 15 minutes or so, and then if you send questions in, which you can do by just putting it on your screen, we'll try to pick up your questions and respond to them as well. And our topic this week is motivational interviewing, as I guess everyone knows. But the question is, does everybody who's tuned in know what motivational interviewing is? And I'm not at all sure that they do. So maybe you can sort of briefly explain it for those who don't.
Yeah, the best way to explain it, Michael, is look at it historically. And addiction, motivational interviewing grew out of addiction field. In the 80s, I was head of a social work department in a hospital. And what we were discovering is addiction service. And what we were discovering was that about 75% of the patients were not coming back. And people dropped out after 3 and 4 sessions. It was very disturbing because really nobody was getting care. And the reasons why they weren't getting care was explained by these people being hard to reach, unmotivated, you can't trust them, and so on. A lot of attributions, which in many ways stigmatized this population. And so I was wondering at that point whether there was something we can do that perhaps it wasn't something that was inherent in the client, but maybe we weren't approaching them that way. If you looked at, I did a little study and I found out that if I asked the patients what they expected for addiction, they expected something quite different, which was they expected brief treatment. They expected that the therapist would do most of the talking. And they also weren't sure whether they had an addiction problem to begin with. So given that situation, just coming in and telling them that you're lying or confronting people or shaming them, we often would do.
That's the way that a lot of drug addiction treatment worked in those days. I remember it well.
That's
confrontation groups and encounter groups and a lot of shaming.
So we did that. So people there were very much felt like they had nothing to do. These were unmotivated clients. And so I said, well, maybe there's something that we could do in the way we approach these people. And at the same time, there was an article by Bill Miller who wrote about state versus trait. And that motivation was not a trait. It wasn't inherent. There wasn't alcoholic personality. But motivation was a state which could be modified, and perhaps modified by some kind of interaction. And
so in this, the state was a state of lack of motivation.
State was where they were, their situation and circumstances. A lot of people were being forced to come in. They were mandatory, right, and so on. So they weren't sure what they were doing there and what they happened to be there. But some part of them was saying, well, maybe I really didn't need to be there. So there was a state of ambivalence, we called it, versus a trait which was alcoholics can't be helped. They're very counter-dependent and so on. So if it's a state, that meant it was modifiable and somewhat you can do something in the interpersonal relationship.
You mentioned ambivalence, and one of the things that I've learned, I don't know if I've learned it, but I've heard it along the way, I'm not an expert on motivational interviewing by a long shot, is that it almost starts with the assumption that everybody's ambivalent about everything.
That's probably true. Yeah, but any kind of change, there's always been stages of change, and there's a contemplative client that's not sure and so on. And that represents a significant proportion of people. If you really are motivated and you really want to change, that's not motivational interviewing. You don't need that for motivation. Right. But you've come in there with uncertainty or unsureness or reluctance or not clear whether you got a problem, you have a solution to the problem. Something's got to be done about that process. And so that's where the birth of motivational interviewing came, that there was something you could do differently than just expecting people to tell you what they wanted to change and so on. And so out of that grew this process of motivational interviewing. And so we did a number of experiments in that process, and we saw people coming in regularly, and they were talking about it. At the same time, at this time, Bill Miller was writing a book called Motivational Interviewing in Australia. And so Bill and I met in '88, and we were doing a study on brief intervention. And we decided that rather than call it brief intervention, which was really kind of like inadequate, we said, let's call it motivational interviewing, or let's call it motivational enhancement therapy. That was a little more sophisticated. And out of that 1988 study called Project Match, we began to see some data that was explaining somehow we can change people through a process.
So if prior to this what was happening was some people who had problems of addiction were being sent for treatment, which
right.
They maybe wanted a little bit, but or maybe they were being forced. And then once they got there, they were being informed, you've got a problem.
Right.
And we need you to you have to change your behavior.
Yeah, we're addiction service, and what are you doing here if you're not going to work on the problem? It's an addiction service.
All right. So how does it change? How do you get to people who are, in some cases, they don't even know they're ambivalent, but a lot of people are ambivalent. I'd like to give up drugs, but
the key to that is that a person is not going to talk to you about their ambivalence because they may be unconscious about it. But you have to create a comfortable environment, a safe environment, so people can exercise their ambivalence and talk about it. So you don't start with, here's a questionnaire, here's the question. You start with and say, Michael, what brings you here today? Or some open-ended question.
Well, the court sent me.
Yeah, well, then we talk about that. And let's talk about the court and what happened, or what can you tell me about it? And in that process of interviewing, and there's a whole bunch of techniques, open-ended questions, affirmations, reflections, summaries. There's a whole bunch of techniques that's called motivational interviewing. I tried to get you to at least to talk to me about what your uncertainties are, what your ambivalence are, so we can join together in a shared decision-making on a collaborative process rather than adversarial, is translating this into a collaborative partnership. And actually, we have worked very successfully with that process, particularly in non-addiction services where people are coming in for health problems or other kinds of problems. So it becomes much more useful even in that setting.
Yeah, I'm particularly interested to talk about how it's being used in the health sector these days. I mean, I think it's very important that we address the problem of addiction in our society, which is obviously an enormous issue. We've got the rise of drug overdose deaths now, which is I think it just leveled off last year for the first time in a decade or so. So
You're
obviously
absolutely right.
addiction is a huge problem, and motivational interviewing can be used to address that in some ways.
I'd say about 10% of the people that come into these healthcare centers actually go and get treatment. And even though their substance abuse issues are very much, either it's created or it's related to it or it's made things worse, most of them don't get really care they need to help. And so where motivational interviewing comes in is that most of these people, we call them non-help seeking because they don't have a problem. But in the midst of talking about some emergency room service, they had a car accident, usually some kind of issue comes up around addiction. And often that's a very predominant part of the problem itself. And when motivational interviewing is help to emerge these discussion about these emerging problems.
So in emergency rooms, especially as I understand it, there's a process that has evolved, which is evidence-based, that's known in short as SBIRT,
right?
Which, if I'm right, stands for screening, brief intervention, and referral for treatment.
Right.
Well, I got something right. And how is motivational interviewing? You've got somebody who comes into the emergency room. They've got a crisis situation to deal with. How do you engage with somebody?
Well, in the trauma centers, number one, they actually built it in. It's part of the they have a trigger or a screening, and they look for addiction problems, in this, especially in trauma center. They're required to. And so they do a brief screen and maybe 4 questions and so on to see whether alcohol or drug had played a particular
Is the screening
role.
verbal on paper?
It's actually is there instruments for that? Is actually you can have one question screening issue. You can say, do you have any attribute your injury to drinking beforehand? You make something question like that.
Right.
There's a lot of data on one screening questionnaire, and that can identify a significant proportion of people. It doesn't mean they have a diagnosis or an assessment, but once that trigger comes up, a whole process comes into play. That's where the brief intervention comes in.
And what is the brief intervention?
The brief intervention is really looking at the person to talk about something about their severity of the problem, how serious it is, their concerns, other people's concerns, and trying to develop a kind of collaborative or compatible relationship, and maybe give them some brief advice. Often the case is not serious enough, and so they can talk about, ways they might help reduce their drinking or alcohol use in a brief one-session intervention itself. For people that are more serious or more severe, they probably will need a referral. And that's another kind of technique of MI, is how do you make that referral? And so a lot of brief works for a lot of people, but for more serious, it's more of an issue because you have to make the transition to another service.
Doing referrals is often problematic, leaving aside the parts of the country where there's no one to refer to, which is, of course, a problem. Even where there's some place or somebody that you can refer to, I think the data indicate that if you say to somebody you ought to go see a psychiatrist, for example, fewer than half will follow up on that.
Yeah.
And so here we are in this emergency situation that you describe. It's a one-time connection with a person. How do you get them to follow up?
Well, that's the motivational interviewing. The process is getting the person to argue themselves into change, rather than you fostering them by my discussion with you, eliciting issues, things like self-motivational statements, affirmations, summarizing people's anxieties about it or concerns about it. It helps the person some kind of way to discuss and say, maybe I should look at that thing, or after talking to you. Because if you get confronting the client, they're probably not going to do it. They're going to be angry and resentful. But if you can discuss with them in some way that's interactional in a relationship-building process through engaging and rapport building and so on, you might be ready to open up and say, what got me here, I have been drinking. My wife's been expressing her concerns, and my boss has been saying something about it. Maybe there is something I could do about it.
One of the things that I learned along the way was built on this notion of ambivalence, that if everybody is ambivalent and you authoritarianly, if that's a word, take one side of the ambivalence, namely you've got to stop doing what you're doing, it enlivens the other side of the ambivalence.
That's exactly, there's a lot of data in that too. You're absolutely right, absolutely right. If you go one way, you'll get you actually have an exercise of pushback. Somebody pushes you, and you end up pushing them back. That's a normal response. What we're doing now is with our students is that we're actually teaching them those strategies and those techniques so they can learn how to engage with people, that people who are not expressing their willingness to help, how do you engage with that population?
So I understand something is going to change next year at the school, and there's going to be some training in motivational interviewing for people going into field placement.
We have what we call a boot camp, and a boot camp is to get some basic essential skills around rapport building, affirmations, reflections. Reflections particularly because we find that asking questions and probing and so on really, as you said before, engenders a reaction. They put people on the spot. So we teach students how to reflect rather than to ask questions. It's a big paradigmatic shift for social work students not to ask questions.
That's really interesting. Are you going to do some research on the impact of this?
Well, there's a lot of research already. Hopefully, with all the students involved, we have done we actually are giving some pre-post questions right now, and we are giving them, students have to show a tape at the end, which we can then monitor and code in terms of its proficiency in MI skills. We're actually doing that right now. And I am training a whole cohort of lab instructors so that every student will have an opportunity to have that 7-week training. It's a major change, and I'm doing that right now. We have the second, third cohort of training going on right now, and we've had a number of students through the process in the pilot phase. And the students, it's like duck to water. They really feel it's very helpful.
It sounds very interesting and very positive. I mean, I know from my teaching here that a lot of first-year students just feel so overwhelmed when they start their placements in the first year. They are starting out to deal with people with some very difficult problems, and I mean, having a skill like this, it strikes me, would make life easier for the student.
Well, some of the comments I get,
or more comfortable for
students
the
say, I shouldn't be yelling at my clients. No, I don't think that's going to help. Or I shouldn't be confronting them, or you know. And I said, you got to be very careful about how you can relate to people, because you can be as harmful as much as helpful.
Well, I'm looking over at the screen now to see if we have questions, and indeed we do. We have 2 questions so far. One is, are there key themes that tend to emerge in clients' motivations?
Yes. They go through a number of processes. One is they begin to think about it more. They think about maybe whether their awareness or they recognize the problem, which is in one phase. And the second is, are they accepting of the solution? So if you've got a problem with alcohol, and I say you have to go to 12 meetings, it might help to go to 12 meetings a week. I'm not going to 12 meetings. So there's motivation around problem, and there's motivation around solution. And sometimes the two don't go together. Somebody could say, yeah, I got a problem, but I'm not going to go to get any help with it. Or sometimes they haven't got the resources. We have to consider that as well. But those are the basic framework.
Okay. And a second question, does motivational interviewing work with teenagers who are actively using drugs or alcohol?
The truth is that motivation has been useful for wide, diverse populations, and cross-culturally, cross countries, cross ethnic groups, cross age groups, aging. What students find out, it actually works with their friends and their relatives and their families. Students that speak to my grandmother now differently. So it's a much more generic, we call it MI spirit. The MI spirit pervades everything. And as social work practitioners, we should be receptive, because basically the relationship building is the key what we do. And giving people autonomy to have their own decisions is what we do.
Well, you just mentioned a kind of interviewing spirit. Can you comment more on that?
Yeah.
And then you talk to your grandmother differently?
Yeah. Well, the grandmother differently is that there's 4 parts of the MI spirit, which is compassion, so showed compassion, engagement, you can listen to people and engage with them. One is to support autonomy, which is giving people choice to change. And so those are the processes we're looking at in terms of spirit. And every student should have that spirit. And that may not be the best terminology, because it sounds more religious, but it really talks about relationship and collaboration. And it goes back to Carl Rogers and what he's been saying.
You say it goes back to Carl Rogers. Just comment on that quickly, and then I'll read another question.
Carl Rogers basically advocated was the relationship building to genuineness, commitment, compassion, empathy. He said that is what helps people change. When MI says yes, but you need something more, it doesn't happen automatically. You have to give people some direction and some structure. And so the Carl Rogers group say, no, you don't do anything. Just that's going to happen. But the evidence doesn't seem to support it. So MI said, let's try to draw on Carl Rogers, and let's take it one step further. What could you do with that relationship? How could you move it in some direction?
That's interesting. So it's not just listening, it's actually providing some direction to your clients, patients, interviewees, or whatever.
And that's the MI part of it. And we've talked a lot with Carl Rogers' group, and we always say, yes, that's great as a first step.
Interesting, interesting. So here's what is the training process for professionals who want to use MI in their clinical practice? Do they receive supervision? Is there a certificate? I'd add another question. How long does it take to learn to do this?
Well, there's different stages. You know, there's depends on how you're using MI. For some people, it's sufficient to give them some basic information so they can work in a more primary care, limited role as an add-on to what you do. That's a foundation process. And then there's people around working as kind of an intervention tool itself. And that requires sometimes more proficiency than just some of the basic skill, rapport building techniques. There is a certification, but it's not official. There's a group called Motivational Interviewing Networks of Trainers, and they go around, they train people, and they give you a certificate. But officially, there's nothing.
There's no licensing.
Yeah,
in
but
this.
some states, like North Carolina, do mandate it for probation officers.
Oh, really?
Yeah.
For probation officers?
Yeah, particularly for probation officers.
That's really interesting.
Yeah. And people at the school, Craig Schwalbe has used it within a probationary setting. He's done some work in that area. I'm not the only, so you're interested in that area.
So here we've got a person who has presumably committed a crime, has some history of unacceptable behavior, and the probation officers who are trying to do two things, help them to maintain a life in the community that is safe and productive and satisfying, but also make sure that they are towing the line.
Well, it's a dual role,
Yeah.
which is somewhat incompatible with
Right.
the role, so one has to wear two hats. And I've worked in this kind of setting myself. You say, these are the rules I have to do. I've got to check your urine, blah, 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 blah. Given that situation, how can we work in that framework? How can I be helpful? What are things you want to work on? Because it's motivational requires an interactional shared
Right.
process. So there are things that you cannot share around certain rules and compliance. There are things they can share. I want to work on be a better parent to my kids. I want to be a better husband. That's not a probationary rule, but that's something where motivational interviewing can play a role within that context.
That's really interesting. You also mentioned, this is my question, I'm not looking at the
Yeah.
screen, but you also mentioned that people can work in a primary care setting with fundamental motivational interviewing skills. Can you comment on that? By primary care, I assume you mean primary health care.
Yeah,
Yeah.
there is actually in the motivation, a member of the motivation, there's actually a subgroup at the MI Motivational Intervention Network of trainers that really work in primary care settings. So the physicians, and we have lots of tapes on it, a lot of resources, who are being trained on learning how to help people improve health behavior change, rather than giving them, I'm your doctor, I advise you to do that, is asking them, what do you need, and what is something that you want to do, or how can I be helpful in this process? So engage them. We actually have little skill building workshops where you learn how to ask questions or how to provide reflections to people rather than. So, and I've done a lot of training with doctors myself, and I say, you're being a doctor right now. You're not being a motivational interviewer, which gives the client, and a lot of its influence. You see that you've got a physician right now. They're much more listening right now and then being more attentive rather than telling you what they think they need to do.
That's interesting. I wrote an article many years ago now that had something to do with motivational interviewing based on some of my experience. Many doctors told me I had to lose weight, and that means eating less and exercising more. I knew that, but every time they told me, I went and had a bacon cheeseburger and French fries. So it was pretty clear that just telling me that I had to do it wasn't going to work. And
that's the response.
How can a doctor motivate
right.
or help me to get the motivation to do it? But I raised another question, and that was,
usually
how can we motivate the doctors to want to use motivational interviewing rather than just taking the commanding position they usually take?
Well, if you say to them it works better and more effective than what they've currently been doing, and if that's if they want to help people, and they want people to change, this might be an alternative approach than continuing on this kind of authoritarian model.
I'm being told I have to look at the questions over here
Okay.
now, and let's do that. Can you give some examples of interactional and affirmation building statements?
Okay. Affirmational statements differ from, this is a big lecture, but I want to go, different than praise. Praise is not affirmations. Praise is something that you bring and you tell them, and it could be somewhat patronizing if I praise people. Affirmation is something you tell me about yourself that you're proud of, and basically I affirm it or reflect back about what it is. It's a major difference between affirmation and praise. And praise comes from your needs, what you want to tell them that may make you feel better. But that's not the issue here. Oh, you're great. I'm so impressed with you. That kind of stuff. That's a big difference between affirmation. Actually, we have a lot of techniques around that. We do that.
Can MI be used effectively with clients who have already acknowledged or overcome their ambivalence but have yet to take next steps?
Good point. That's a very good point.
Okay.
They found out that you can help people deal with ambivalence and reflect attitudinal change, but you shortchange them on the steps. And what we found out is that the planning process is an important element. And so usually that's the last phase of MI. And people sort of, assume they're going to do it. But the planning process is just as intricate by getting people to take ownership, to get more details, to get more steps. So it doesn't happen, people will change automatically because, I got to change my addiction problems. But I might ask you, how are you getting to the 12-step meetings? Or are the meetings, any concerns about the meetings? I might have to go into more detail so that we can have some joint discussions.
But the point is to get beyond an attitude change to a real behavior change.
You're learning.
Well, you must be a very good teacher. Look at this. It's not even a half hour
You're
yet.
motivating me right now
And this
to motivate you.
And this is affirmation at work.
Yeah, it's a joint affirmation here.
Very good. What else do we have here? You said the MI spirit involves 4 things: compassion, engagement, supporting autonomy, and you didn't give a 4th.
I have a senior moment here. I think
Okay, so we'll come back to that. You have to be kind to us older people.
It's in the literature. You can get it right away.
How can you use MI for those who use marijuana recreationally? Well, another question is, should you use it for people who use marijuana recreationally? With pros and cons part of MI, what can you use as the consequence? So the question seems to assume that using marijuana recreationally is ipso facto a bad thing. I don't know whether you would agree with that.
Yeah, motivational interviewing is different than that's not what motivational interviewing. We're not defining the problem of people, what they should be working on. It's something the client has to decide with himself. And it's the focusing. If you really want to change some issues around marijuana use, that's something we want to work on. But we don't impose problems onto people. We try to get them to focus on what they think is important.
So for a person who is enjoying using marijuana and it's not having consequences in their lives that they are troubled by or other people are troubled by,
well, it doesn't mean we don't give information. If something is dangerous, if using certain drugs is dangerous, we might say to them, but we say it a different way. We ask them we ask permission. We say, can I tell you my views about that? So you can take some responsibility for listening. So we don't provide no information. We do give information out, but in the context of a decision-making process. It's a whole different process.
This is a really important issue right now. There's an article in the New York Times today. I don't know whether you saw it. Talking about the different views there are among experts about whether marijuana use contributes to schizophrenia. And the article, I thought, just sort of said, well, we don't know. And it may be that at some levels of use, marijuana can be dangerous, as other substances can be, and maybe not. So but it's a very live issue now as the new laws are being drafted and new regulations are going to have to be developed about
and we will integrate that. We talk about medication, for example, with addiction. And in many ways that was seen as imposed. Now we'll talk about medication as an option. And there are a lot of options and so on. And the options are in the context of what we know.
So on that note, we have reached 12:30, I see, and that means that we are about to end this session of Social Work Live. Some people would like to know, how can they sign up for your motivational interviewing boot camp?
This is for incoming first-year students, and they have been advised right now about it. They have information right now. We'll start another group for all students in the fall. But right now we have a boot camp for the 16-month students. And those students are
So the first answer to the question is become a student at Columbia University School of Social Work.
That would help.
And the second answer is that there are probably some other resources available. Is there a website they can look at where they would find information about other ways to learn about motivational interviewing?
Yeah, there's a motivationalinterviewing.com or .org, which has a lot of motivationalinterviewing.org has a lot of information on the whole process.
So, Alan, I want to thank you for joining us
Thank
today.
you. It's fun.
It's been very interesting, and I hope it's been interesting to our audience, and I hope the audience will come back next week when I will be talking with John Robertson. And John has just developed something called a, believe it or not, listen to this, a MOOC. I think that's MOOC. And if you want to know what a MOOC is and how it can help you to learn about social policy in the United States, join us next week and we will answer these questions. Thanks for joining us today.